Mark, can you hear me? Mark, can you hear me?
Hello, Dr. John. How are you?
You can hear me okay?
I'm here today.
Can you hear me? Can you hear me okay? Mark, can you hear me?
Okay.
You can hear me? Mark, can you hear me? Hold on. Okay, Omar, can you hear me? Can you see me? Can you hear me?
Dr. John, I not see you. I hear you.
Can you hear me or no?
Yes, I hear you.
Oh,
Okay.
good.
Sound is good.
Hey, okay. Tell me if this music is familiar to you. Okay, I'm going to play it now,
Okay.
and tell me if you hear it. Do you hear that? Do you hear it, Omar?
Yes, Dr. John, I hear you. Sound
you
is
hear-
very good.
Do you hear the music?
No music.
Okay, let me.
Only your voice.
Okay, let me try again. Okay.
Okay.
Yeah, that's what I'll do. Hold on, I'll screen share it.
Dr.
I got it. Okay.
Today.
Okay, Dr.
Okay.
Sbeih.
That is very nice.
Yeah,
Share is
okay.
very good.
Yeah. Can you hear that?
Music, Dr. John.
So you hear the music?
I hear music, Dr. John.
Okay, good.
Okay.
That's Arabic music, right?
Okay.
Okay. Okay, we start in a few minutes. Dr. Sbeih, in 20 minutes.
Okay, no problem.
Okay.
Wait.
Be back. Hello, Nargiza.
Hello, good evening, John. How are you?
Good. We got to get you a good background.
How are you?
Something exciting, dynamic. The exciting neurosurgeon. Electrifying, strange.
John, I completely forgot. On Sunday, we have to be ready with banner for Russian Grand Rounds. It's not yet ready yet, so I will have to do it today night.
Oh, well, I can do it if you send me the stuff.
Sunday. Okay, you can do that, but I have to send you the information, right? So
Yeah, of course.
I completely
Unless you want to do it, you're probably busy as hell, right?
Yeah, I am too busy, and after that
Hey,
we can...
give it to me. Give me the information.
Okay.
Yeah, as much as you can.
Just 1 second.
Okay, I'll be back. And that's not me barking. Hello, Omar. Omar, are you there?
I am here, Dr. John.
Yeah, I'd like you to meet Nargiza Sartova. She's
Okay.
Good evening.
Sartova,
she's a
Nargiza?
neurosurgeon.
How are
She's a neurosurgeon from Ukraine,
Uzbekistan.
Uzbekistan.
I'm from
Sartova, how are you?
Uzbekistan.
How are you?
Nice. Thank you. I'm fine.
very happy.
Yeah, Omar's a big fan of ours from Syria.
Wow,
Thank-
great. Oh my God, I was recently talking about the Syria, and I wanted to visit Syria because I'm studying in Istanbul right now. I'm doing pediatric neurosurgery there. And Turkey is has border with Syria, and I was just thinking like I would like to go there. So see.
Well, get his email address. Omar, send Nargiza, put it in the chat, your email address, okay, Omar?
Okay.
Yeah, Omar's been doing these webcasts a lot.
Wow, great.
He even comes to the Spanish ones, but I don't think he speaks Spanish.
Soon we all will speak Spanish as well. It's the second language after English, as I know.
Oh, in America is getting very popular.
Yeah.
And the population, the second, it used to be the white population is first, but then the black was second, but now it's the Spanish that are second as far as the size of the minority. Isn't that a little interesting tidbit?
It's not easy to, or it's not difficult to learn Spanish as well as I know.
It's very similar to English. I didn't have a hard time at all because a lot of the key, especially in medicine, a lot of words are almost the same. Enfermería, infirmary, very
Mhm.
similar. And skeleton, that's, So you're going to introduce Dr. Sbeih, right? I'm going to introduce you. And then
Okay.
do you want to introduce him? Okay.
Yeah, I will. Just 1 second, I have to get prepared because today will be Dr. Ibrahim Sbeih, Mohammed Sartavi, Asil Sbeih. So 3 people.
Well, whatever's appropriate, you neurosurgeons know I'm an outsider.
No, you are not.
Oh, okay. Did he give you your email? I don't see the email.
Me too.
Did he give you his email, Omar? I'll tell him, Omar.
Mhm. Okay.
Okay, dear Natiba. Satoba, the email, read the email.
Yes, I saw your email. Thank you so much.
Thank you very much for that. Thank you.
Thank you.
Welcome to see you.
Hey, let me try to catch
Yeah.
some. Right. Okay, Nargiba, this is just to get you in the mood.
Okay. Arabic.
Can you hear that? No. Can you hear that? You like it? Good day, Dr. Sbeih.
Hi, John.
How you doing?
I'm fine. How are you?
Very good.
Okay.
Nargiza's here.
Yes, I can see.
Good evening, sir. Good evening,
Good
Professor.
evening. What time do you want us to start, John?
Assalamu alaikum. Dr. Sbeih.
7 minutes, 7
How are
minutes.
you?
Thank you. All right.
You remember Omar, right? Omar? Omar,
Dubai. Okay, I'm here. How are you, Dr. Sbeih?
How are you? I'm fine. Shukran.
Alhamdulillah. Salamat.
so Nargiza, how are things going in Turkey?
Things are going well. So
You had
far,
a full
so
day,
good.
full day?
Yeah, I was at the hospital, then it was OPD, outpatient department, clinics and all these things. I
Oh,
was
okay.
kind of busy.
So it was not an OR day today?
No, it was OR. We had surgery in the morning, and after that, after lunch, I went for polyclinic OPD.
But you'd rather spend the whole day in the OR, right?
Sometimes, yes. For example, yesterday we had 4 surgeries, and yeah, it was the whole
What
day.
kind of surgery? What
4
kind?
surgeries, 4 cases
Oh,
was.
four cases? But not long ones, obviously.
3-4 hours, yes.
Okay, well, that's
Sometimes it can be long.
that's
Yes.
not a small procedure.
No, it is. It depends on experience, on the speed of the surgeon. So all these things are all together.
Just make the saw bigger. Well, that's what they did in the old days.
Mm.
But hopefully we're past that.
Mm.
See, who else can you meet here? Yeah, we got Venezuela. We have that big conference. You know what, Nargiza? I'm not going to use the breakout rooms.
Okay.
It's just more complicated, and I'm going to have a lot to do trying to admit people that need to be admitted.
Mhm.
For security reasons, Zoom won't let you just let people in, like the doors open. They
Mhm.
don't. You have to have some kind of security.
Mhm.
So I gotta manually admit them but I'm trying to find out from them, is there a way I can give them a link to directly get in? I think there may be. But and I talked to some programmers from India who specifically said they have dealt with breakout rooms. And I said, okay, fine, send me an example, but they really couldn't send me one
Mhm.
because of some kind of non-disclosure agreement. So I said, well, you know what? And they didn't seem too enthusiastic. That they said, oh, we're going to do polls, we're going to do this in the breakout room. And then when I met them, it was like, well, they told me about the minimum thing, and that was it. So I'm going to wait on that to try to evaluate it. See what's going on. Dr. Pujari starting his pediatric neurosurgery grand rounds
When?
in India.
When?
I believe the 13th. The Friday, next Friday, not this Friday, but next Friday.
Yes, I got it.
Yeah, he's great. I always kind of had a hope that someday I'll be having him give lectures on pediatric neurosurgery for India. I mean, this is a guy who was a big educator before the internet, and he really likes the internet. He really appreciates. So anyways, it will be starting shortly, hopefully. If anybody wants to come in the panel, just
You are ready, John?
okay. You ready? Okay.
Well,
Okay, hold on here. Okay, can I get you off the screen share, Dr. Sbeih, so we can introduce you? Okay. Dr. Sbeih, can I get you off the screen share so I
yes,
can,
sure.
yeah, that way I can introduce your face. And Nargis is going to actually introduce you. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach. This is Dr. John Bennett, home of Neurosurgical TV. We have another Jordanian neurosurgical grand rounds with Ibrahim Sbeih. We've been doing these for a long time. And we're going to have Nargiza Sartova give Dr. Sbeih the proper neurosurgical introduction. Good day, Nargiza.
Good evening, everyone. Salam alaikum. It's my honor to introduce today one of the giant neurosurgeons in the Middle East as well as in the world, Professor Ibrahim Sbeih from Farad Medical Campus, MRCS, FRCS, the member of a lot of international societies, WFNS, ANS, the organizer of conferences, courses, and workshops inside and outside of Jordan, well-known neurosurgical educator. Also, today I would like to introduce Mohammed Sartavi, facial-maxillary surgeon from Farad Medical Campus, and also Asil Sbeih, Bachelor of Medicine, Bachelor of Surgery, board-certified neurosurgeon from Farah Medical Campus. Today's case presentation will be on cranial aneurysm bone cyst tumors revisited, case presentations with multidisciplinary approach. Thank you, Professor.
Thank you, Dr. Sartova. We'll just start now.
Okay,
For our
perfect.
audience here, can you hear me, John?
Yeah, perfect.
For our audience here in the auditorium and for our audience on the internet, my name is Ibrahim Sbeih from the Farah Medical Campus in Amman, Jordan. And today we are going to present the cranial aneurysmal bone cyst, which is now called the tumors. We will revisit it with my colleague, Dr. Mohammed Sartawi, and my daughter, Dr. Asil. This is going to be a clinical, radiological, pathological correlation kind of presentation. To start with, in that area, we need to know the anatomy of where we are going to operate. And may I call upon Dr. Sbeih to present the anatomy of that area.
Good evening to our live audience and hello to our online audience. We will start with the anatomy of the orbit. So we will be using pictures and information from this paper done by Sir Albert Broughton about the macrosurgical anatomy of the orbit, which he calls it the rule of 7. So in the orbit, they did in this paper So in this paper, they decided to do classification of the orbit. So it has 7 bones making the orbit. It has 7 nerves going into it, and it has 7 muscles. But we will be talking about the bony anatomy for the sake of this lecture. So starting with the bony anatomy, we have 7 bones making up the orbit. We will start with the orbital process of the frontal bone here. We start with the zygoma here, with the maxilla, with the lacrimal bone, with the ethmoid, and this is the sphenoid, and somewhere around here is the palatine bone. And the orbit is a four-sided pyramid. It has its apex posteriorly, and it has an anterior base, and its axis is directed medially. And this direction actually helps us see in the 3D vision that we see, and it helps us see the range that we see. This is an overview of the orbit from above. So this is the globe, this is the orbit, and this is zoomed in picture. So we see the angulation and the axis that we have talked about. We will start with the roof of the orbit. So the roof of the orbit is consisted of the orbital plate of the frontal bone and the lesser wing of the sphenoid bone. So we'll start with the orbital plate of the frontal bone. So this is here, the frontal bone. We're looking from inside. This is the orbital plate of the frontal bone here, the orbital plate of the frontal bone, and the lesser wing of the sphenoid. So this is the body of the sphenoid, the lesser wings, the greater wings, the pterygoid plates. And in this case, and in the roof of the orbit, the lesser wing makes up the roof of the orbit in addition to the orbital roof of the frontal bone. So this is the orbital roof of the frontal bone and the lesser wing making up the roof of the orbit. Another image where we take the frontal bone and we put the sphenoid with it so we can appreciate how large the roof is and how the orbital plate of the frontal bone and the lesser wing make up the roof. So lesser wing, orbital floor of the frontal bone. Again, frontal bone, lesser wing of sphenoid. Regarding the medial wall of the orbit, we have the lacrimal bone, we have the lamina papricia of the ethmoid bone, and we have the junction of the body of the sphenoid with the lesser wing of the sphenoid. So here again, lacrimal bone here, lamina papricia here, which is the lateral wall of the ethmoid, and the lesser wing of this, or the junction of the lesser wing with the body of the sphenoid here. Lacrimal bone, lamina papricia, and the junction of the lesser wing with the body of the sphenoid. And when we talk about, if we're gonna mention the lamina papricia, we might as well talk about the ethmoid bone. So this is the ethmoid bone here. It has 2 labyrinths, the right and the left labyrinth, and we have a perpendicular plate in the middle, okay? So this is it here, the ethmoid bone, the crista galli, and the cribriform plate. These are the air cells here where it articulates with the frontal bone, ethmoid bone, and here it is from above. This is how it articulates with the frontal bone here, here, and here. And this is the orbit again. So this is the lamina papricia, which is the lateral part of the ethmoid bone. And this is how the ethmoid bone sits in front of the sphenoid. So it articulates with the body of the sphenoid. And this is a coronal section of the ethmoid bone where we can see the labyrinth here and here and the perpendicular plate. And this is the lamina papricia here. And this picture shows us how thin the lamina papricia is. So when we do endoscopic surgeries for orbital lesions in the medial part of the orbit, it's easy to get into the orbit when we go through the lamina papricia because it's a thin bone. Again, a coronal view, ethmoid, perpendicular plate. This is the labyrinth with the superior and middle turbinate. And this is the lamina papricia here and here. Can anyone tell me what these are? Anyone from the audience? So these are the anterior and posterior ethmoidal foramina where the anterior and posterior ethmoidal arteries go. And this is a very important landmark when we do surgery, whether it's cranial surgery or endoscopic surgery, because these are landmarks to where we are. So everything anterior to the anterior ethmoid is related to the frontal part of the anterior fossa, or we can say that any lesion anterior to the anterior ethmoid is a bulbar lesion. Anything posterior to it is apical lesion, and it has a relation with the planum sphenoidale, and everything between the anterior and posterior is a retrobulbar lesion. So again here, bulbar, retrobulbar, and apical lesions according to the anterior and posterior ethmoid, frontal, cribriform, and planum according to these landmarks as well. Lateral wall, it's consistent of the greater wing of the sphenoid and the frontal process of the zygoma. So this is the greater wing of the sphenoid here. And this is the frontal process of the zygoma, making up the lateral wall of the orbit. Greater wing, and the zygoma, here, here, and here. The floor of the orbit consists of the orbital surface of the zygomatic bone, the orbital surface of the maxillary bone, and the orbital process of the palatine bone. So this is the orbital process of the maxilla. This is the orbital process of the zygoma, and this tiny part is the orbital process of the palatine bone. Again, the zygoma, how it articulates with the frontal bone and the maxilla, here, here, here. The maxilla, how it articulates and how it forms the floor of the orbit. And this is to imagine how the maxilla articulates with the frontal bone. And these are the nasal bones. This is a very nice picture showing how the maxillary bone and has the maxillary sinus and how it's covered with the inferior turbinate bone. The superior and middle turbinates are part of the ethmoid, but the inferior turbinate is a standalone bone, and it basically covers the maxillary sinus. And this is the palatine bone here, articulating with the posterior part of the sphenoid. This is to show us the palatine artery, the course of the palatine artery, which we should know if we're doing endoscopic surgery in this area. The palatine bone is a small bone, and it has a horizontal plate and a vertical plate and a horizontal plate with two processes, the sphenoidal process which articulates with the sphenoid, and the orbital process which makes up a small part of the orbital floor. So this is it, how it articulates with the sphenoid here. So this is the vertical plate and this is the horizontal plate making up the hard palate. And this is to imagine how the palatine bone sits in our skull. I think it's quite a nice image. And when we talk about the floor of the orbit, we should mention the inferior orbital fissure and the inferior orbital groove. These are important landmarks because through the inferior orbital fissure, we can go medially to the pterygopalatine fossa or go laterally to the temporal and infratemporal fossa. So the inferior orbital fissure here going into the inferior orbital groove. And from here, we have the infraorbital foramen, which has the infraorbital nerve coming out of it. So maxilla, zygoma, and this is the pathway for the inferior orbital groove, and this is the inferior orbital foramen. Again, this is the maxillary sinus here, And we can see the nasolacrimal duct here, which please pay attention to it. We will be seeing it in our surgery today, and the infraorbital nerve from the infraorbital foramen. When we talk about all of these walls, we said it's a pyramid. We have an anterior base and we have an apex. The apex is the meeting place of all of these walls. And we have the optic canal there, which has the optic nerve and the ophthalmic artery running through it. So this is the apex here. This is the optic canal. This is the optic strut connecting the lesser wing of the sphenoid with the body of the sphenoid. And in this area, we have a tendinous ring called the tendinous ring of Zen, which is the origin of the extraocular muscles. So optic nerve, this is the optic lesser wing, and this is the optic strut. This is the tendinous ring of Zen. And these are the contents of the tendinous Zen ring. It has the optic nerve, the ophthalmic artery. We have the 6th and 4th nerves, and we have the nasociliary branch of B1. And this is just to imagine that we cannot see the optic canal from a front view. We should do a small tilt so we can see the optic nerve and the superior orbital fissure together. The orbital rim, so the frontal bone is the orbital rim, the frontal process of the zygoma, the orbital part of the maxilla, these are the orbital rim. And we cannot talk about the orbit without mentioning very basic anatomy of the nasal cavity. So we said that the medial wall of the orbit is the lateral part of the ethmoid. So we have the perpendicular plate of the ethmoid making up the nasal septum. The upper part and the lower part is made up of the vomer, and the anterior part of the nasal septum is cartilaginous, as we know. This is another image of this. And again, as we mentioned, that the superior and middle turbinates are part of the, or conchae are part of the ethmoid, and the inferior turbinate is a standalone bone. And this is the opening for the nasolacrimal duct. Superior and middle turbinate. This is the superior and middle, and this is the inferior one. So we'll go back to Prof. Sbeih to talk about aneurysmal bone cyst. Thank you.
So we've seen that the anatomy of that area is rather complex, and one should not go for surgery in that area without mastering the anatomy for the finest detail. Now, the topic of tonight is the aneurysmal bone cyst, the so-called ABC. A standing for aneurysmal, B for bone, C for cyst. What is ABC? First described by Jaffe and Lichtenstein, 1942, they said what? Opening the cyst, there is a thin wall with a large hole containing fluid blood. And they call this.
So the sound is very low.
I know, we were trying to fix it now. The lesions of the bone are made of.
It was okay for me. Anybody else have a problem with the sound?
Should we wait a little bit, John?
Okay, just go ahead. It seems okay for me. Nargiza, does it seem okay to you?
The voice is breaking in between.
Okay. Oh, so I didn't
So
notice
the
that. I'm sorry.
lesion of the ABC is made of cyst like this,
Yes.
and there are septa here in between containing connective tissue, giant cells, and so on. So this is the ABC.
Okay. Just let us know, Nargiza, if it breaks up. Okay.
Am I okay, John?
Okay.
Cystic part, which contains the blood, and solid part, which is rather fleshy. What is the cause of the ABC? They said that there is a trauma. Trauma causes some circulatory disturbance, increased venous pressure, venous thrombosis, AV fistula, and increased hydrosis blood flow, like this. And this would cause bone erosion, thin cortex, bleeding into the cavities, and the bone will collapse. It is either primary or secondary. Primary meaning that it is not associated with other lesions. Secondary means you'll see a bone pathology with associated ABC lesion. Secondary ABC is seen in many tumors like giant cells, osteogenic sarcoma, Langerhans histiocytosis. All these tumors and lesions can have some changes of the ABC. Papers about this from USA 98, concomitant fibrous dysplasia with aneurysmal bone cyst. And this paper, association of ossifying fibroma with bone cyst. Now let's settle it for once and for final. The last 2020 WHO classification of bone tumors, ABC is a tumor. So please stop using the word.
Excuse me, Dr. Sbeih. Dr. Sbeih, I'm sorry to interrupt you, but the people are complaining, they just can't hear it well. Is there anything we can do? Can we adjust anything, or is the technician there? Is the technician there to kind of play with the hearing? Because there's a couple of people that said it's not clear. Yeah, 3 people said it's not clear.
I'm trying to fix it.
Okay.
I'm sorry to say that my assistants are not good because I said, do the doctor knows, and they assured me it is okay.
I'm not a good judge. I can't hear at all.
Are we okay now?
That's better for me. How's it for you, Nagiza?
It's better. Let me just ask, is it?
Go ahead, Ibrahim. Go ahead. Can you speak, Ibrahim? Try it now.
To Sbeih from the microphone, I think.
Let him play with it.
Hello, do you hear me?
Yes, we can hear you. We can hear you.
Yeah. Okay.
Let's try that. Let's try that.
Are we okay, John?
Yeah,
Yes,
it's
much
good
better.
now.
Thank you.
It's good now. Better.
Good. Yes.
Is it better?
I think so. I hope it stays.
Okay, should we continue?
Yes, please.
Okay, so 2020 WHO classification of bone tumors decided that this is a true neoplasm, and some changes are seen in the other pathologies. Hold on, this here. Aneurysmal bone cyst is a disease of young, 5 to 20 years, equally in males and females, and it constitutes 1% of all primary bone tumors. Which bones are affected in our bodies? The long bones and the upper limb and the lower limb, the pelvis, the spine. The last thing, the minimal thing is affecting the skull, cranially. So this is a bone, aneurysmal bone cyst tumor in the humerus. In the spine, it affects more on the lumbar spine. And in the skull, it affects the frontal and parietal more, affects the ethmoid and sphenoid sinus more. From India, this paper about the frontal bone aneurysmal cyst, as you see this way, and another massive ethmoidal aneurysmal bone cyst tumor. It can affect the temporal bone, occipital bone, as you can see, ethmoid bone. From Korea, this orbital lesion affecting the orbit. From Turkey, affecting the sphenoid bone and the clivus. Cervilopontine angle. Jugular foramen from Iran. And this very unique paper from India saying this is intracranial, intradural aneurysmal bone cyst, which is very, very unusual. Let's see the Mayo Clinic experience about this ABC tumors. Ethmoid sinuses are the most common. If you have a lesion in the orbit or there is nasal discharge and obstruction, they have poor outcome. In general, ABC tumors in the skull base are very rare. How do they present in that area? Facial swelling, proptosis, nasal obstruction, vision changes, epistaxis, headaches, facial pain, nasal discharge, anosmia, and the duration between the presentation and the symptoms can be few days to few months. Images now for those ABC. And the plain skull X-ray, there is some scrub lesion like this. And the CT again will circumscribed lesion, multiloculated. And in the MRI, you can see that it is hypotension T1 and T2. There are the fluid levels. It is not pathognomonic of aneurysmal bone cyst tumors because it can happen in other lesions. So here, ABC tumor, multiple fluid levels, but ABC can happen also in chondroblastoma and osteosarcoma and others. Very unique paper telling us this. Fluid level can occur in other lesions than ABC, chondromyxoid fibroma, allergic rhinitis, esthesioblastoma, and chondrosarcoma. And this very unique paper, recent, this year from Vietnam, a vestibular schwannoma with the fluid level. So fluid level for radiologists is not pathognomonic of bone cysts. What about angiography? It's important because it can show us the feeding vessel, whether the ophthalmic artery or occipital artery. So there is a blush, and you'll see the periphery is vascular, while the central is avascular. Three cases here, the feeder is coming from the maxillary artery. Here the feeding is coming from the ophthalmic artery, and here the feeding is coming from the occipital artery. The treatment of these tumors, skull base bone cyst or bone cystic tumors, the difficulty is that it is young age. Sometimes the accessibility is difficult because you are going to the skull base, very vascular, with huge blood loss, and the high rate of recurrence. Who is going to deal with these lesions? The ophthalmologist, the oculoplastic, the neurosurgeon, the neurologist, the maxillofacial, ENT, oncologist, interventional radiology, radiotherapy, and internist. So it is teamwork. The treatment is basically in these forms: surgical resection, curettage of the contents. You can give radiotherapy. You can inject something to cause sclerotherapy, or you can give chemotherapy. Fine needle aspiration is not recommended because it's often non-diagnostic, and there may be some bleed. So curettage and bone grafting is well known, but not good in the skull. It is more in the peripheral bones. Sclerotherapy, injection of intraosseous calcitonin and methylprednisolone. Again, sometimes difficult in the skull base, but often successful in long bones. This case of skull base chondroblastoma with bone cyst changes, so fluid level. They have taken biopsy and they treated it with radio frequency. And something recent is to use the concentrated bone marrow injection in some diseases. Embolization sometimes is used to decrease the blood supply so that you can operate with less loss of blood. It can be curative, it can be palliative. This is a case of petrous bone, aneurysmal bone cyst, And this is the blush of the angiogram, and this has been treated with embolization. Another case supplied by the occipital artery after embolization. So embolization can be used pre or as a curative. And this case among us, myself and Dr. Farid, of one case of skull-based aneurysmal bone cyst. Dr. Farid, can you come over?
Hello, everybody. My name is Farid Al-Adham. I am a neurointerventional radiologist. I'll try to go quickly through a kind of unusual case referred to Dr. Ibrahim Sbeih. This is a form of minimal invasive way of dealing with aneurysmal bone cyst in an unusual location. We'll skip the ways how we go through this, but as Dr. Ibrahim mentioned, this can be treated through intralesional injections with just simple needle access. Sometimes we do embolization or combining this with some form of ablation, percutaneous ablation. Our case is unusual because the location of this lesion, as you could see, this characteristic multiple cystic with fluid level in the region of the occipital condyle and the skull base posteriorly. Another view demonstrating the very challenging location. This is on the other side. You could see where the occipital condyle. This is the lesion with multiple classic features of aneurysmal bone cysts. Very challenging surgical location for surgical treatment. This is again showing the lesion, large cystic component eating into the occipital condyle compared to the other side, with the enhancing soft tissue around it. This is illustrating how the occipital condyle looks and its relationship to the adjacent nerves and canals. So the way we approach this case, initially we decided to do endovascular embolization of the cyst, the mass, and follow that with percutaneous ablation. This is initial angiography of the external carotid artery, and immediately you identify posteriorly here through the ascending pharyngeal artery the vascularity of the tumor. This is more obvious vascularity of this tumor with multiple areas of contrast pooling within the cysts that are within the tumor. This is through the ascending pharyngeal artery, selective injections. Going into the other supply of this tumor, this is the vertebral artery. These are branches of the vertebral artery supplying the tumor. This is a very selective injection of a branch of the vertebral artery, demonstrating the large areas of blood pooling within the lesion. This is after we embolize those branches. This embolic materials that you see right here are inside the tumor cyst and supplying branches. What we did after that, under guidance, we approach this, the white material you identify is the embolic material we deposited within the tumor. And then you have this percutaneous access into the tumor. This is a radiofrequency ablation needle. As you could see, this CT, this is done intraoperative, where you could see the deposited embolic material within the wall, and you have the radiofrequency needle within the tumor. This is immediately post-embolization, recognizing we embolize all those soft tissue components within the wall of the tumor. This is immediate, this is pre-operative, This is just 2 months after. You notice immediately the collapse of the tumor expansion, the tumor size. This is post-operative, and you could see this. This is what was left from the occipital condyle. This is the embolic material after. Again, pre-operative, you identify the tumor here with the soft tissue component inside it. Post-operative, this is the margin of the tumor with beginning of ossification. Another example showing how large the tumor was in the skull base posteriorly. This is a very critical space to surgically approach. This is post-surgical, where you could see actually beginning of forming, reforming the shape of the condyle at that location. Same thing here on the CT. Post-operative, I will skip further images. This is just to demonstrate how the bone reossify and form after these kinds of minimal invasive interventions, especially in very critical spots. I will skip further because I want to show the MRI. This is another example how the tumor on this side was almost, you don't identify any margins of the bone. Post-embolization, you actually start identifying a very similar axis to their normal bone. You do actually see the residual of the occipital condyle. Moving forward, I will skip to the MRI. This is again pre and post-operative, as you could see. This patient most procedural, pre-procedure had severe headache. He had cranial nerve 12 palsy. After the procedure, he did develop partial cranial nerve 9 palsy that recovered after 2 months. And this is obviously had to do with the ascending pharyngeal artery embolization, and that was expected to some degree, and he recovered from that. This patient had by now almost, actually, he just had his follow-up MRI less than a month ago that showed consistent results with no recurrence of the tumor, and the patient has complete resolution of his previous symptoms. This is quickly, not the last MRI, the one before that was actually a year ago, which is essentially 2 years after the procedure. This is pre-operative. You see the classic features pre-operative, and both intervention 2.5 years after, you only have residual fluid-filled small cavity at that area at multiple sites. This is 2.5 years after. This is pre, this is post. And that's an example of how to minimally handle these kind of complex cases. Thank you. And now we did it in 2020, actually 1 month before.
So you can see interventional surgery can be sometimes useful. What are the surgical approaches for such a lesion? Either transfacial, as you will see it to our case, transcranial with endoscopy alone, or combined. But radical excision in the skull base, ABC, cannot be achieved most of the time because of the location. Historically, the region of the orbit has been always a neurosurgical, and it should remain so. Now, these are some papers from Joseph Maroon, a Lebanese neurosurgeon, world famous for the orbital surgery. So in the 80s, 90s, and so on, this area of the orbit was ours.
Excuse me, Dr. Sbeih, you're going off the screen. Your face is going off the screen. Okay.
Are we okay now?
That's better. Thank you. Sorry to interrupt.
Let's go to this paper published by Mayo Clinic.
That's
They
good.
had 89 patients, and they used 54 for open surgery and 20 cases for endoscopy. Some cases done by surgery from USA. So surgery by neurosurgeon is still the mainstay. And as I said, a combination of open surgery or endoscopic. The same paper from Mayo Clinic, they say in conclusion, When evaluating surgical approaches, there is no difference in outcome in open or endoscopic, so they are the same, though I and Dr. Sultan believe that surgery has the upper hand. Endoscopy is also useful. Case from France using endoscopy for excision of these lesions. And again from Turkey 2014, the endoscopy. And this is one case where you can see the image as you go in with the endoscope, the picture of the tumor coming up. You can use radiotherapy after subtotal resection, or if there is recurrence, or if it is progressive, or if it is inoperable. A paper from India about the role of radiotherapy. The tumor recurred again, and they had radiotherapy treatment. Again, from Mayo Clinic, 89 patients, 70 had the gross total resection, and 4 people had post-operative radiotherapy. Recurrence rate is high, so you follow up for patients for long periods of time. Recurrence can happen 6, 7, 8 years after surgery. There is very limited spontaneous regression reporting in the surgery. My experience in the orbital lesions is 126 cases between benign tumors, malignant, and others. And as for the ABC tumors in that area, these are my cases. So I will present one specific case, a 7-year-old male patient from Iraq. That goes back to 2017. He reported 3 weeks history of right eye proptosis. Notice, 3 weeks. Sudden onset, 3 weeks. Photophobia and decreased vision. Looking at his forehead, there is a scar. So maybe this theory of trauma is applicable. You can see the proptosis. Best seen if you are looking this way from the top of the head. Quite obvious, this disfigurement actually is there. So this is the right eye, pushed forward and downward with limitation of eye movements. Left eye is intact. And then if you do the conjugate eye movements, and then together with staccato movements or pursue movements, you will see this. This is essential. You examine each eye separately, and then you examine conjugate eye movements. We should look for the proptosis index. And this is the famous Frankfurt plane, the line between the anterior rim and the greater limb to the other limb. Both eyes should be symmetrical. In this case, you can see they are asymmetrical. So Frankfurt line is important to see the proptosis. General examination of this patient was 15/15 Glasgow Coma scale. No weakness, no cerebellar signs. Hematology was within normal, nothing unusual. And the preoperative images showed this. You can see this lesion here in the orbit, in the ethmoid bone, on the right side, pushing and going into the right orbit. Actually, it's also reaching to the sphenoid sinus. Same thing here, it is in the roof of the orbit. Again, here, occupying the ethmoid bone totally and the sphenoid sinus. I hope you will remember this image when we go to show you the operative pictures. This area will you can see the medial rectus is pushed and the orbit is pushed. And remember that he had very poor vision in his right eye. You can see closed level. Use T2. And this is the CT scan. Complete destruction of the ethmoid, activation and destruction of the sphenoid, and we are going into the medial wall of the right orbit, meaning that we have invaded the laminar picture of the ethmoid bone. So this is the CT scan. bony window and soft tissue window. And this is the coronal. Again, you can see there is intracranial extension. Now we don't know, is the dura intact or not? Most likely it is, because you can still see the rim. So we are invading intracranially, but with the preservation of the dura. Dura is very resistant, by the way. And this is the ethmoid, and this is going into the maxillary sinus. And again, you can see the middle turbinate is affected. This is the optic nerve here, being pushed. T2 coronal. The proptosis, the bone erosion. Extensive bone erosion. Lamina papyracea is gone. Synod sinus is invaded. Cervical process is involved. And this is the sagittal showing the anatomy here. You can see again that the turbinates are affected, mostly the turbinate. And this is the 3D bone CT scan showing that the medial wall and the roof are affected. Angiogram is essential to see the vascularity of the lesion. For me, MRI. Yes, I would not do MRI alone, never. Venogram is important because the venous anatomy changes are various.
Kurt,
And,
doing a webcast now from Jordan. Do you want to come? You want to come in?
So we did some consultations.
Okay, I'll talk to you after it's done. Sure, I'll talk to you after it's done, okay? Okay.
Good evening, everybody. I had the pleasure to evaluate this boy. Actually, I remember this boy well. I usually don't have feelings with patients. I don't sympathize with them, but this was different. This boy was cute, handsome, and lovely, and the lesion was nasty, disfiguring, and potentially blinding. In our evaluation, we evaluate function and structure. So function like visual acuity, visual field, and color vision. We evaluate structure like the eye lobe itself and the eyelid, whatever the structure of the optic disc. So if you notice, we have problems with the function of this kid. The visual acuity was counting fingers in the right eye. The color vision was 0 out of 17. Visual field, usually we do the automated visual field, the Huntley visual field, but unfortunately we can't do this in kids. This is difficult with kids. So we do this by confrontation. It's not that accurate. But it was full in both eyes. He was able to count fingers. And interestingly, the fundoscopy, there was no papilledema or atrophy. So the OCT was also consistent with the findings of the fundoscopy. There was no thinning of the nerve fiber layer in both eyes. If we have optic atrophy, we have thinning of the nerve fiber layer. If we have papilledema or swelling, we have thickening of the nerve fiber layer. So the impression was that there was right optic neuropathy and proptosis. You saw the proptosis and the dystopia. That seems recent because the structure of the optic disc looks well, while the function is subnormal. So this indicates that surgical intervention should be carried out soon in order to improve vision. So usually with Dr. Sbeih, I usually write a simple impression because usually he does the consultation and most of the time he has an idea about the surgery. But sometimes, especially in these cases, he wants me to intervene and tell him, is this very urgent or not? And in these cases, if we just leave the patient for few days, he will be blind. So usually I call Dr. Ibrahim and tell him, please, doctor, I listened to the optic nerve and he was telling me, please, doctor, save me. So that's what happened.
So this is Dr. Ibrahim Sadat's ophthalmological assessment, telling me, go ahead, try to save this patient's vision. And this is the visual assessment that we did. Any ophthalmology about Ibrahim? Please, want to ask something? You want to say something? We asked for the anesthetic consultation, and they declared this anesthesia American Society grade 2, which means that we are in great danger. So I consulted with my colleague, Dr. Mohammed Sartawi. We discussed the ins and outs of the approach. We sit together looking at the MRI, CT, and then decide the approach. We decided with the anesthetist that it's going to be nasal intubation. And I'll take you back 30 years ago, 1993, myself and Sartawi operated on this patient with the clivus chordoma using the facial approach of maxillotomy. And here we are 30 years after joining forces. We have done so many cases together. And here we are, myself, Dr. Sartawi, the kid with his father and uncle, just minutes before surgery. So may I call upon Dr. Mohammed Sartawi? Mohammed is a maxillofacial surgeon. He's a senior one with vast experience.
Really.
And get his face centered if we can.
It gives me great joy.
Yeah,
And,
look at the screen. Look how you look on the screen.
Ibrahim was, I've known him for donkeys years ago. We have done so many surgeries together. And till we find my section. Okay. So, ABC, to my mind, is a benign tumor, but acting in a malignant fashion locally. So it is a malignant tumor locally. And this is me, and I'm going to skip all these. And who has been practicing for a long time? Let me go back to this. Those of you neurosurgeons who've been practicing for so many years will probably end up with this condition that I have noticed with Ibrahim and in Japan. So I want to skip also all these because they've been covered really well with my colleagues. And as you can appreciate, I've only been given a few days notice to join forces with Ibrahim and present this case. So I will skip all these. Has been really explained really well by the Sbeih family. And this is a child when he presented it to me in my office. And as my colleagues described, he's a heart-breaking child. And I do these usually to compare the proptosis on one side and compared to the normal one. And this is the child at the minute he was entering the operation. First stage usually is the engineering that is entitled by a maxillofacial surgeon. And this was the technique we use, we call Weber-Ferguson technique, which is usually subciliary. It's under the eye, but we modify it according to the needs to become with ethmoidal extension, which is far more difficult one, to be honest. And this is how we do it. I'm going to advance it a little bit so that you're going to see many videos of the procedure. And this is the extension of the ethmoid. And then you go under supraostomy to protect supraorbital and supratrochlea. And hence it goes in the area really well. The current maxillofacial access to such tumors, and I agree with my friend Ibrahim that this is really a tumor. It's not simply cyst. And the current technique that people use to approach such tumor is the maxillectomy, because the term maxillectomy is no more existing. It's wrong. It's myth. We call it maxillectomy because the maxilla are two maxillas joined together. So they're not one maxilla that you would consider as maxillectomy. So this technique, as I felt so sympathetic to this child, I thought to myself I should develop the technique, and it was really what I've done. I call that technique Sartawi Sinonasal Orbital Skull Base Segmental Osteotomy, SSO. And that's with the new osteotomy cuts that are really non-invasive, if you like, compared to the maxillectomy. I call the cuts nasal, maxillary, zygomatico, orbital, segmental osteotomy, NMZO. So this is my invention, if you like, my baby. And the technique is, as you see, the red indicates the nasal osteotomy, and the M indicates the maxillary osteotomy, and the Z indicates the zygomatic, and the O, the white, is the orbital. And as you can see here, this is the nasal part of the surgery. So you need to do very meticulous in these surgeries, and you should choose your assistant really well, because there's no room for mistakes, to be honest. And this is okay. So that was the nasal part, and this is the maxillary. Now there is a trick here, because those of you who are not exposed to terminal teeth in a child of 7 years old, they are very close to the primary teeth. So you need to go further up by at least half a centimeter to be able to protect the permanent teeth budge, that we call budge. And this is the second cut. And then we proceed to the zygomatic cuts, which is like so. We protect the infraorbital nerve, and this is infraorbital nerve, and we do the cut vertically, as you can see here, and this is the intract infraorbital nerve. And since we talk about infraorbital nerve, you can either you have the option of three things. Either you sacrifice it because it could be passing through the tumor, or make a groove, a knee groove, and pass it through that groove to avoid traumatizing it, or you can widen the hole itself quite well around there, and you can move the window that you have created laterally. Okay, so we have three options, and so this is the maxillary. It's obvious. Now what's left? We need to perform the orbital osteotomy, and this is a very challenging one because you need to have a lot of experience and expertise using the mallet. And many people don't know how to use a mallet, to be honest. They use their whole arm. So when you use a mallet, you use your left rather than, and you can appreciate that the mallet is so small as well. Now, hammering this infraorbital, as I mentioned earlier, there is the infraorbital groove. So you need to appreciate where that groove is and how the nerve is passing. And I think I'll advance a little more. Okay. And I even deepen the osteotomy cuts by widening it through another touch of a hammer. And the final stage is to actually use the optichrome to enhance the cuts that they've done. And as we know earlier, that the medial wall is already destroyed by the tumor, so we don't really have a wall but I need to reflect this as a whole window laterally. So this is the complete picture of it. The same thing, okay, and this is the end result. As you can appreciate here, that the flap, if you like to call it a window, the bony window, is being reflected, exposing the whole of the maxillary contents and the ethmoid, the sphenoid, really up to the cranial base, and this is the nerve being protected. So I actually lifted that bone with enlarging the whole of the infraorbital nerve laterally, and now the real job starts by removing. And this is who knows what this is exactly. So you need to say that you need, as Ibrahim said earlier, you need to really be very meticulous and you know your anatomy really well. If you don't, you'll end up in a deep ditch and you will destroy the image of this child. And this is how we started removing from the maxillary sinus, ethmoid, and sphenoid. And it is a teamwork, and I'm very proud again, proud that I work with Ibrahim, because we both respect teamwork efforts. We respect our ophthalmic surgeons and UNT, and whoever is the team member with us has a higher value in our mind. So this is what we've done, and I've advanced further. I must admit I have stolen a bit of what Ibrahim shared here. Okay, and this is the content that I removed. Second stage, Professor Ibrahim Sbeih, again, he budges in with his colleagues, and I leave the microphone till I come for the third stage. Here you go.
So the first stage of the maxillary surgery is finished. Now I have the field in front of me. Now you put the microscope in whatever way it suits you. So it suited me to put it this way. This is the roof of the orbit here, and this is the medial wall. So we have to keep this in mind as we go along. These are still pictures, so that you are orientated of the video that we are going to show. Now I'm holding the tumor with my forceps. So this is the tumor, destroyed bone, and connective tissue. So this is the tumor. Again, this is here the medial wall, and here is the roof. So I'm working between the angle between the medial wall and the roof. As this is the roof, I can see starting to pull the tumor from the dura of the anterior cranial fossa. Remember, it has invaded intracranially. The dura is still intact, so I'm taking the tumor with me away from the dura here. I'm pulling it, peeling it off from the dura, and then here I have to preserve the nasolacrimal duct, which is going this way medially, and this is the tumor here. Here I'm confronted with the medial turbinate. I'm going medial to it, see if there's any tumor. I'm going medially towards the sphenoid sinus. This is the tumor. This is the sphenoid. If you recall the image that we've seen, the tumor has invaded the sphenoid sinus, and this was the cyst within the sphenoid sinus. So to be a neurosurgeon, you have to be a good ENT, you have to be a good ophthalmologist. Otherwise, leave neurosurgery. So we are in the cavity of the sphenoid. I'm using the navigation probe to see where I am. So I know that I'm here, near to the anterior clinoid process. Again, these new gadgets are important, but at the end of the day, it is your brain which is the navigation system. If it disagree with the machine, just discard the machine. As Professor Roten said, you have to have X-ray vision to be a neurosurgeon, like Superman. So this is the microscope, and this is the navigation system that we use. Again, here I am on the posterior part, the junction of the medial wall and the roof, and I started to have heavy bleeding, and the bleeding came from the posterior ethmoidal artery, which I cauterized. It's important that it does not slip from your hand and disappear. So at the end of the day, this is the dura of the anterior clinoid fossa hanging down. Sphenoid is free, and this is the globe and the nasolacrimal duct, which I am above it. And we put dural sealant to prevent any CSF leak. So now back to the video, sorry. So this is the video. So this is the motion picture of what you have seen on the still pictures. The tumor, this is the roof, this is the middle wall, or middle, let's say. Destroyed bone, lots of spaces, lots of blood. This limb is not even, so I trim it to make it even, not sharp, to damage the soft tissue. You can see this is normal bone and this is abnormal bone destroyed. This is the nasolacrimal duct, and this is the middle turbinate. I'm going medially into the nasal cavity. So Dr. Satawi paved the way for me to reach the data areas. If it was not, then it would be difficult to do the surgery without him. So again, this is the teamwork. It should be always appreciated. You can see the tumor is cystic. Look at the blood contents. It's venous blood, serosanguinous fluid. And again, I'm trying to peel up the tumor from the dura of the anterior clinoid fossa. Remember, this is the roof of the orbit. This is the medial wall. Very vascular. All the time I'm remembering the anatomy, where I am. Rarely I use the navigation to confirm. If I'm happy, I'm happy. So peeling the tumor off the dura. That's the tumor being hit to the forceps. You can see the cysts within the tumor. Again, peeling it off from the dura of the anterior fossa. Now I go medially. This is the sphenoid sinus. The cyst within the sphenoid, the tumor within the sphenoid. The idea is to remove the tumor totally, completely, or at least subtotally, if you can't. I am within the sphenoid, and I confirm this with the navigation probe. Removal of the tumor from the sphenoid, and then facing the bleeding from the posterior ethmoidal artery. I was not afraid of this bleeding because I know where it's coming from and I knew how to control it. But you can see these tumors are really vascular. Sometimes you have to stop the procedure because of the heavy bleeding. So this is the bleeding from the posterior ethmoidal artery. And there it is being cauterized. This is the dura and anterior fossa. This is front sinus here. Well, I'm working above the eye globe, above all these structures. So here we are again. So no sinus here. There's no lamina papacia. It's gone with the tumor, confirming where I am. And then wash to take the bad products out. And then put some hemostatic material. And then put some dural sealant to prevent any CSF leak. Okay. Now comes the third stage. Dr. Sartawi will continue the reconstruction.
Thank you. Reconstruction is not a big deal, to be honest. If you, as English people say, fail to plan, plan to fail. So we have to plan ahead what's our protocol of treatment and what. That machine. Okay, so really, I would say it's a piece of cake, the third stage, because all it takes is to reduce and fix. هذا شوي. So before I reconstruct the area, I've already, as I said, to plan ahead what I need to do. So I place holes where I dismantle the bony segment, so I know exactly where to put it back. But if you don't do this ahead, you will be lost. So all it takes now is to. Now, if he was my son, I wouldn't have liked to place a titanium plate through, because it will stop his development and the bones will not grow. Eventually, he will have asymmetry. So I decided to put a plate, which is called biodegradable, the plates and screws. And as you see here, I put one plate here and one plate there, and that's all it takes. And this is the Weber-Ferguson technique with ethmoidal extension. Histopathology, as we said, it's ethmoidal one cyst, an irregular one cyst. Now, 6 years post-op. That's why I asked my friend, Dr. Farid, about the post-op follow-up period after the intervention, and he said 3 years. And here we go. We have 6 years post-op, and this is a child with minimal difference, to be honest, and he's grown up into a young man. And I want to compare the video before and the video now. 6 years on the road, post-operatively. All the nerves are intact, all the functions are restored. I'm really proud with working with Ibrahim to have achieved such a beautiful result. And if you meet the parents, they are so ecstatic. They couldn't believe that they have actually, had given their child the best treatment there is. And at the end, I think I need to thank every member. Yeah, this is also important. So I don't know if I can enlarge this. And this is a radiology report from Iraq, showing you that really the tumor has been eradicated and there is no fibrous dysplasia fluid. There's nothing suggesting recurrence. So the patient is cured, hopefully, and as Ibrahim said, it is from 1 year to 8 years follow-up to determine if the treatment was perfect. And this is the X-rays post-operatively, and I'm sure Ibrahim is going to touch upon it as well. You can see the symmetry here of the proptosis. There's no proptosis anymore. The bone is really healed. And if you look closely to the bone, it's been set back into the perfect position. And thank you so much for being good audience. Here you go.
So we got those tissues sent for Dr. Pasach. Sam, are you here? Please.
Uh, I'm also proud to work with Dr. Ibrahim and Dr. Sartawi in this very interesting case. And really, this is summarize the teamwork in this case. Aneurysmal bone cyst, as Dr. Ibrahim mentioned, it has been changed to a tumor by WHO in 2020 because they discovered there's a gene alteration, USP6, and it should be considered part of the pediatric tumors. So that's why it usually occurs in young patients, in children and young adults. So if you have a patient that is in 30s or 40s that was diagnosed as aneurysmal bone cyst, you really have to throw a big doubt on this diagnosis, because aneurysmal bone cyst can be primary, and this is the tumor, and can be secondary. What we mean by secondary is that it could be as part of the histopathology of other tumors. And one of the most important other tumors that histopathology you should differentiate between them is giant cell tumor. Both giant cell tumors and aneurysmal bone cyst, they have many giant cells. That's why in WHO 2020 they have been put in giant cell rich tumors. But it's very important to differentiate as a pathologist between giant cell tumor with secondary aneurysmal bone cyst or primary aneurysmal bone cyst, because they have different treatment and different prognosis. For example, I want to mention, like a few months ago, I diagnosed a case, or somebody that one of the pathologists diagnosed a case as aneurysmal bone cyst. When I reviewed it, you have to search for very good samples. I found evidence that this is giant cell tumor with secondary aneurysmal bone cyst, and this has changed a whole lot of the game. And giant cell tumors, when you correct it, it's very likely to recur. Aneurysmal bone cyst, the recurrence usually is up to 1/3. So the recurrence and the treatment is different when you diagnose which. Aneurysmal bone cyst can also be secondary to other tumors like fibrous dysplasia, chondroblastoma, or other tumors. So when you have aneurysmal bone cyst in the wrong age, which is above 20, you really, as a pathologist, it's your role is to search for any hidden primary tumors, and could be secondary aneurysmal bone cyst. This is the specimen that I have received. It is a lot of bone and fibrous tissue, and usually it's not a mature bone. And usually the description by pathologists, there is a lot of fibrous tissue. As you can see, there's a lot of fibroblast proliferation, and this is part of the tumor. But when you go in other areas, this is what we call woven bone. This is part of the histopathology. As a pathologist, you have to recognize this is not osteosarcoma. Sometimes pathologists that is not really very good may diagnose this as osteosarcoma or telangiectatic osteosarcoma, which is one of the major differential you have as a pathologist to rule out, because the treatment is obviously much different. So you have woven bone. Woven bone is the bone that's immature. When the bone becomes mature, we call it trabecular bone. And you can see a lot of fibroblasts. But then you go in other areas and you can see here's part of the cortical bones that is being destroyed, or the good bone. And this is the woven bone, or the bone that's immature. And you can see a lot of fibroblastic proliferation, and you can see a lot of bone destruction. This is the original bone of the maxilla that's been destroyed. And this is the bone that is formed by the tumor. And you can see here, this is like a cystic area, and there's usually many giant cells at the periphery of this cystic area. You can see this is again
cystic area and many giant cells. We see higher power for this. You can see this is what we call, this is the nasal cavity ciliated cuboidal columnar epithelium, and this is the multinucleated osteoclast type giant cells. It's very important to recognize which type of giant cells, because there are so many different types. If you see osteoclast type giant cells, not malignant giant cells, then you see fibroblastic proliferation and you see wobble you know that you are diagnosing aneurysmal bone cyst. Again, you can see the cystic areas here, and this is the fibrous area forming part of the wall. And many giant cells, usually they are located in the periphery on the cystic area. The cystic area are not lined by endothelial cells, as you expect. This is lined by fibrous tissue. So that's why it is loose, and you can see bleeding in it, and which is usually considered vascular lesions. Again, here you can see more. You can see sometimes hemosiderin-laden macrophages, as in this case, and you can see the giant cells in the periphery and fibroblastic with moving bone. Again, you can see the giant cells. This is important. When you see giant cells, you have really to differentiate whether it is giant cell tumor or aneurysmal bone cyst, because finding giant cells does not mean it's giant cell tumor, but giant cell tumor, they have typical features or differential features different from aneurysmal bone cyst. And because the differential sometimes can be close, now there is an immune staining, we can tell whether this is giant cell tumor or it is aneurysmal bone cyst. You can see how the cells are very vascular. These are the giant cells, and many RBCs stacked in between the loose type of giant cells, not forming a compact type of tissue. Again, you can see how much is the bleeding, and this is why we consider it vascular tumor, and there's a lot of hemosiderin deposition. This is again the cysts. Some of the cysts are lined by fibrinous material. And again, here you can see the different cystic spaces. Here you can see the original bone that has been destroyed, and this is the nasal cavity. And you can see here is the tumor that's having many giant cells with myxoid areas in some areas. Sometimes even we can see mitosis in aneurysmal bone cyst. Mitosis in aneurysmal bone cyst is not bad. So for pathologists that are not really trained to see mitosis in some benign tumors, they may consider this is malignant tumor and give wrong diagnosis of malignancy. So mitosis is expected to be seen in aneurysmal bone cyst. Sometimes it can be even a frequent mitosis, but when you diagnose something, we take the whole picture. And you can see here is typical the cystic areas that we see in aneurysmal bone cyst. Again, here more of the cystic areas that we can see with many giant cells, stroma, osteoclast type giant cells. This is typical osteoclast type giant cells. Usually the cells are many cells, sometimes with the nuclei, prominent nuclei, but they are not really hyperchromatic or bad giant cells. And you don't see atypical mitosis. We see mitosis, but we do not see atypical mitosis. And this is very important to differentiate between benign and malignant. Any time we see atypical mitosis, like Mercedes ring sign, this is usually malignant tumor. When we see mitosis alone, this does not mean malignancy. You can see some mitosis here. So this is the aneurysmal bone cyst, benign, primary, and the only thing that we have to guard is recurrence, and that can occur up to 30%, and usually depends on the extent of the surgical excision. Thank you.
So our patient did well postoperatively. We referred him from the ICU, staying there for one night, and he was discharged home on the 4th day postoperative. And as Dr. Satao showed you, this is the immediate post-op and the follow-up over the years, 6 years of follow-up. In fact, I phoned his father just 5 days ago, and he sent me recent pictures and recent images. So the proptosis has disappeared, and we did a good job actually. And this is the MRI. You can see very good position of the globe. And this is the CT, the coronary view, the sagittal view with the CT, and the 3D one only. So thank you for listening. And John, are you there? John?
Yes, Professor, we are here. Thank you very much for excellent topic today. We are waiting for the questions from audience. If anyone has questions, please do ask. So far, no questions.
Well,
Any questions?
No questions so far.
no,
Okay.
hold on. Yeah, let me just say, Omar, let me just ask specific people, Dr. Sbeih. Omar, do you have any comments or questions?
Okay, very nice presentation and good professors. Very nice operation. Very nice.
Thank you. Thank you.
Good results. Thank you, Dr. Sbeih, for you and for all staff.
Thank you. Okay, any questions from the audience in the auditorium? Please. Dr. Haitham Azam, radiologist. Now, the aneurysmal bone cyst is recognized as a tumor. This could be sole tumor, or it could be changes within other tumors. The recurrence of the solo ABC tumor is high, and this is because it is a tumor. So stop using the word cyst, stop saying aneurysmal bone cyst, and this is a tumor. Any other questions?
I think
Any
someone just
questions from
asked.
our audience here? Do you have any questions on your side, John?
Yeah, I think, yeah, there's one. Okay, how is the reconstruction of the medial wall of the orbit done?
There's the reconstruction of the medial wall of the orbit. You'll
Yes.
see at the end of Dr. Sartaro's presentation, the medial wall of the orbit is the lamina papyracea, and it was gone, destroyed by the tumor. So removal of the tumor and proper reconstruction will ask the tissues to form a new bone and reconstruct itself. So this is the repair stage of these tumors.
Okay, there's another question. Basically, it's a neurosurgical resident asking about how she would give a presentation, and I can answer that. Mila, you're welcome to make presentations on this channel anytime. Just hang around after, we'll give you instructions and we'll get you presenting. We need presenters. We'd love to have neurosurgical residents and students present. As you know, you learn more when you have to present. Okay.
So John, if there are no questions on your side and we have no questions here, I would say thank you for listening, and we'll join together in 2 weeks' time. We'll present the intracranial fungal infections.
Yeah, well, thank you. People just don't realize how good a presentation this is with a multidisciplinary, but the word will get out. Don't worry. So thank you very much for all you and all your team. Thank you very much.
Thanks to all our audience. We'll see you in 2 weeks' time. Bye-bye.
Thank
Bye.
you.